episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Hey, welcome everybody again to another episode of our show with another fascinating guest who is helping to create a better tomorrow for all of us. So on a recent episode, we discussed this report by the Lancet Noncommunicable Diseases and Injury Poverty Commission that came out in October of 2020, talking about this extreme gap in health coverage for the world's poorest billion, talking about how non-communicable diseases account for more than a third of the burden of disease, account for something close to 1 million deaths in people aged under 40. More than HIV, tuberculosis, maternal deaths combined. And despite many people living in abject poverty, tens of millions of people around the world spend catastrophic amounts of money every year on out-of-pocket costs. And as such, we're honored today to be joined by a guest who is really at the epicenter of this theme with developing solutions. And that's Dr. Ann Aerts, who is head of the Novartis Foundation, which is an organization that's committed to transforming the health of low-income populations around the world, leveraging the power of data, digital technologies, artificial intelligence to ultimately reimagine health and healthcare around the world. Dr. Aerts holds a degree in medicine, as well as a master's in public health from the University of Leuven in Belgium. She also has a degree in tropical medicine from the Institute of Tropical Medicine in Antwerp. And Dr. Aerts is passionate about improving population health through using these tools. She chairs the Broadband Commission for Sustainable Development Working Group on Digital AI and Health. She's also a member of the International Advisory Board of the Commonwealth Centre for Digital Health. She's served as a member of the United States National Academy of Science, Engineering, and Medicine Committee on improving the quality of healthcare globally, sits on the National Academy of Medicine's Healthy Longevity Council as well, and has authored numerous publications on digital health, innovative approaches to multi-sector partnerships to address these challenges. Before leading the Novartis Foundation, Dr. Aerts was a franchise medical director for critical care for Novartis in Basel and therapeutic head for cardiovascular and metabolic diseases for Novartis Pharma in Belgium. And prior to joining Novartis, Dr. Aerts served as director of the Lung and Tuberculosis Association in Belgium and head of Health Services Department of the International Committee of the Red Cross in Geneva. Welcome, Dr. Ann Aerts, to our show today. Thank you for joining us.
Thank you, Ira.
It's great seeing you. I really appreciate your time. Typically, we start things off by just handing our guests the floor for a little bit to introduce themselves. If you could just take a few minutes to introduce yourself, a little bit about where you grew up, how you first got interested in medicine and public health, and a little bit of your career journey. I think that would be a great way to start things off.
Great, thanks, Ira. It's really a pleasure to be here today and to tell you a bit about myself and how I became a medical doctor. Maybe, I don't know if I know it completely myself, but I don't come out of the typical medical family as many people do when you study medical school. But at my teenage time, I think about 15, 16, I was very idealistic and I really wanted to change the world. And when I learned about, at that time, there were major catastrophes going on, major famines in Africa. It was a little later than the Eritrea or the Ethiopia famine. And I was really fascinated by that and how you can alter that kind of crises around the world. So I said to myself, that's what I want to do. That's why I want to study medical school. And then I want to go abroad and work in such situations to see how we can change that and turn these catastrophes around. So really very idealistic, far away from reality, I guess. But in the end, I enjoyed medical school as well, as I love science and I loved the studies. Then when I finished, I still wanted to go abroad, but I decided to first do internal medicine and emergency medicine specifically. So I worked for a few years in my home country, Belgium then. And then I left, I studied tropical medicine at the time, and I left abroad. And then I worked, I guess, for about 8 to 10 years in conflict areas mainly, as an emergency physician. And I ended up that part of my career as the head of the health services in the International Committee of the Red Cross, which is the organization always working in conflict areas. And then I said, no, I really want a normal life. I wanted children and I wanted to become a normal person again. You say to yourself at some point, I guess there's a time for everything in life. So that's what I did. I returned home to Belgium and I got my children, but I worked at that time for my government for a while. That was in the time of September 11, in fact. And in Europe, we were experiencing these bioterrorism attacks, if you remember, with anthrax in the envelopes. So I was called by my government to set up the emergency preparedness unit there in Belgium to address that bioterrorism. And that was fascinating. But after that, it became a very bureaucratic role and I didn't feel at my place there. So that's how I changed sectors again. And I joined the civil society, the Lung and Tuberculosis Association in Belgium for another passion of mine, TB, tuberculosis, to screen that in all the high-risk groups in Belgium, like the drug abusers, the prisoners, but also in the asylum seekers. And I liked that role as well because I had been working in the prisons in ex-USSR where we discovered multi-drug resistant TB. So it was a real passion of mine as well. And then after a few years of that job, I had these opportunities, strangely enough, to join a private sector company, Novartis. And I said to myself, well, if I do that, it's to join my other passion, the science part of medicine. And so I worked for 7 years in R&D with Novartis, first in Belgium, then in the headquarters here in Switzerland. And since now 7 years, I merged my passions together in the role as the head of the Novartis Foundation, where I bring science together with the work for underserved populations and how we can innovate health and care around the world.
Outstanding, outstanding. You know, and when we think of sort of this, what we'll call sort of this poorest billion, but I know there's more than that. We think a lot about the communicable diseases. So you're mentioning your involvement in TB. We think malaria and HIV, of course. But then, as I was saying about this report that we were recently discussing, the non-communicable diseases, major impact as well. Talk a little bit about, if you could give us a little background to the Novartis Foundation. Obviously, many probably familiar with Novartis as drug. I take one of your blood pressure lowering drugs every day. Talk a little bit about the foundation, and then sort of as you look at this poorest billion, we'll say, how do you decide sort of what to work on, what to focus on, infectious, not infectious, because it's such a big pool of targets, let's say, for you.
Oh, yeah, you're absolutely right, Ira. The global health challenges we face nowadays are really unprecedented. And if you want, at the Novartis Foundation, in fact, we are an old organization already. We had our 40th anniversary last year. So our legacy work had been focusing really on these communicable diseases, on eliminating diseases such as malaria and leprosy even. And we were pretty successful. We decreased leprosy, for example, by 99%, but the last miles to elimination are the most difficult ones to cover. And we still focused on that until recently, where we developed, for example, an AI-driven tool to accelerate diagnosis of leprosy based on images of skin lesions, so that everyone around the world could send with his or her mobile phone a picture of a lesion on their skin to the cloud and get a probability back that this can be leprosy. This algorithm and now tool is being developed in collaboration with Microsoft Philanthropies and is going to be using the newest technology we have available to address the oldest disease, one of the oldest diseases known to man, existing since 3,000 years without any diagnostic test ever being available. So that's an example of our legacy work, if you may. But given all the global health challenges, indeed, since 6 years more or less, we shifted our attention at the Novartis Foundation to addressing the leading cause of death currently in the world, which is cardiovascular disease, And it's not only for the lowest billion of the world's population, but it's for the majority of the world. If you may, non-communicable diseases, and specifically cardiovascular disease, have really become the main cause of death in all countries, also low and middle income countries. And 4 out of 5 deaths of all of these problems occur in low and middle income settings. So heart disease, cancers, respiratory diseases, things like that. Hypertension, high blood pressure, for what you just mentioned, Ira, for example, it's responsible for 10 million deaths a year, which is more than all infectious diseases combined. And if you may, we also shift away from working in the remote rural areas like 20 years ago to the urban settings, because most of the poor and most of the world's population anyway lives in cities already. And by 2030, that's going to be about 70% of the world's population. So cities are completely overwhelmed and their health infrastructure is unprepared to address all the challenges they have, combined with a huge shortage of health personnel, skilled health professionals. So to address all that, it's really necessary to take a completely other approach. And that's why I believe COVID is for us, the COVID pandemic is a real wake-up call to show the entire world that the way we are providing health and care services has to change. We have to transform our health services from being those reactive services that look at people when they are sick and present to the health system, to becoming proactive systems or predictive systems with the help of data and AI-driven solutions, to even become preventative ultimately. Because what we want from our health system is that it keeps people healthy instead of waiting until they get sick and present themselves. So we aim at the foundation now, our mission is completely aiming at advancing such data-driven and AI-driven solutions to transform and to improve population health in urban settings. So that's where we currently look at. And we focus mainly on cardiovascular disease, not only because it's the main problem around the world, but also there's so many possibilities, therapeutic options available. Even at the first line level, if you treat your high blood pressure, you can avoid that you do an infarction or a stroke later on. But if you continue walking around with your high blood pressure, which is without symptoms, so many people don't even know they have something like a blood pressure, then you risk to do a stroke at very young age, because that's what we see. In Africa, for example, such diseases, they attack people at a much younger generation than here. So we see very severe high blood pressure in people of 30, 35 years old. You see the hospital wards in low and middle income settings all around the world, not only in Africa, are not filled with HIV anymore, like in the 90s or the beginning of the 2000s. They are filled with stroke patients or infarction patients without having any chronic services available for people with that condition. So that's definitely a very big emergency now. And let alone to address both the pandemic and these chronic diseases is going to be an enormous wave of burden on the health systems that is coming up at us. I don't want to use the word tsunami, but that is what is coming. Because all of the people around the world, we know from research in the US and in Europe, people are diagnosed with late stage disease now, with late stage cancer, because everybody's been postponing to seek health services because of the fear of COVID. And it's logical. People just wait and feel it's nothing, it will pass. I prefer not to go to the hospital with all these COVID problems. So that's a real burden that is coming up to us. We will have to address it together with the chronic diseases and the COVID, because COVID is not finished yet. We will have to address it together as one syndemic. And I see that is becoming even a more challenging issue for all the health systems around the world than anything else we've ever experienced.
Continuing along that theme and thinking about the cities, you you had this a multiple, I think, year program. It was called Better Hearts, Better Cities. It was focused on Ulaanbaatar, Mongolia, Sao Paulo, Brazil, and Dakar, Senegal. And you really put together a you brought everybody to the table, not just the healthcare providers, but food suppliers, employers, insurance funds. And, you know, it makes me think of this theme that we hear a lot about nowadays, sort of these social determinants that it's great to have all this technology, but still, if I can't afford my breakfast, still, we don't think of sort of the ecosystem that surrounds that person in Senegal or in Mongolia. Talk a little bit about the Better Hearts, Better Cities program, if you would, just as an example of how you bring all these different players to the table.
Yeah, the history behind Better Hearts, Better Cities was exactly that, Ira. So we realized that if you want to address an issue like cardiovascular disease, which is far too big for one player alone, you have to do it together with all the possible partners. And we also know out of our population health evidence in the world, or public health evidence, we know that if you address the underlying determinants of the chronic diseases, such as cardiovascular disease, but in fact, they are the same determinants for cancer or diabetes. It's high use of alcohol, tobacco, no exercise, and unhealthy food. It's the main four determinants of cardiovascular disease and other chronic diseases. We know if you address those, you have a much bigger impact potentially on the population health than if you would address only the quality and the access to the health services alone. So you have to play it from both a bottom-up way and a top-down way. If you look at the gaps and the weaknesses in the health system, obviously they are important to address the needs of people who already have the condition of high blood pressure or diabetes or cardiovascular disease. But if you look at the needs of the majority of the population who is still healthy, they may be very different still. So that's why we said we are going to bring together public and private sector players from all these different sectors, not letting us work in a siloed approach as we are used to, but we will bring together the food and agriculture sector, the transport sector, the insurance sector, the educational sector, the workplace sector, and the health sector together with the city authorities. In fact, cities can be really good drivers of population health, if you may, because they are much leaner in their approach to bring together these non-conform partnership or non-traditional partnership, I would say. And it really worked. So working through both the underlying determinants and the health system improvement, which is also a heavy delivery, it worked because, for example, in Sao Paulo, we achieved a tripling of the blood pressure control rates in only 1.5 years of intervention together with the city authorities. So the city authorities are in the driver's seat. And they decide what their priorities are to address this problem. And it's their design that we will work together to co-develop the operational plan for Better Hearts, Better Cities to address all the underlying problems and the health system weaknesses. And that way of working, which is purely needs-driven, it's not politically driven, it's needs-driven, it has to be. That has proven really important to be so successful. And the second part, what made it so successful, is that we monitor everything that was done. So we measure everything that was done, which is something that doesn't always happen in all countries. That you measure the patient outcomes, that you measure what is the effect of the different interventions on the outcomes of people. It's not always so easy. So that's what made it a big success as well, as it helped the city authorities to pinpoint where the progress was going well and where progress was not going well and where they had to change the interventions or intervene in a different way. And this kind of working really has proven dramatically more rapid than any classic public health intervention would have been able to. Because if you speak about tripling a blood pressure control rate in a setting where, like Sao Paulo, which is comparable with any other middle-income country, where you have even the blood pressure control rates comparable to Europe. I'm sorry, not only middle-income countries, but also in Europe, we have like 20-25% blood pressure control rates only. And if you then triple that with this simple partnership that is driven by the city authorities, it is massively impactful on population health. In fact, we know we reduced 30% of strokes in 1 year with that kind of results. So it is really saving a lot of lives and saving a lot of costs to the health system as well, because they don't have to care for people who need long-term rehabilitation then. So definitely the data-driven approach, the mindset shift we introduced thanks to these innovative types of partnerships to use data, but also to use the voice of what is happening on the ground. We included patients and their families in the design of the operational plan. We included all the different stakeholders from civil society, from the academic society, the public and the private sector. And that made it very, very solid. So I think this approach, which we have called it cardio, just to have a nice name of the approach. And cardio the C stands for improving quality of care, which is obviously super important because in the world, many more people die of low quality of care than of lack of access to care. So quality of care is instrumental. Access is the A, and access means to early diagnosis, but also to have your health and care delivered close to where you work or live, or even in your living room. That is what this innovative way of working has to do. The R stands for policy reform, because there's a lot of evidence around the world. In the US, you have, for example, cities that have banned completely trans fat and salt in processed food and have been hugely successful. So we use that evidence to advocate for policy reform in countries. And we've seen that introducing tobacco taxes, for example, in Mongolia, helped to increase the budget for primary healthcare by 300%. So all of these reforms are hugely helpful as well. The D stands for data and digital. The I for intersectoral collaboration, as I said, with all of the different players together. And O is massively important, is local ownership, both by the city authorities, but now also what we are further innovating in this model of cardio is that we want to have much more ownership by the patients themselves. So participatory health and care, where patients take so much more responsibility in following their and monitoring their own health, knowing what they have to do for it. And I think we have to build on the momentum of COVID to do so, because even the most skeptical amongst us have become really convinced about the benefits of virtual care and accessing digital health services and all of that. So I think COVID will help us build a stronger way to digitize our health services where patients can take that responsibility. So have that participatory health and care.
It's amazing all the things that that COVID is affecting, and if this is one positive one, it's and I like Kaleo. It has a nice ring to it. So thank you for that overview of that program. And before you said you didn't want to use the term tsunami, but I'm gonna bring up tsunami now because there's another tsunami coming that we talk a lot about on this show called the Silver Tsunami, or the tsunami of aging. Major demographic changes occurring in every country around the world. You are on the International Commission that oversees National Academy of Medicine's Healthy Longevity Challenge. I had the honor of serving with Victor Zhao on the World Health Organization, the World Economic Forum's Longevity Committee for a couple of years. I had him on a show last year. I'd love to get your top line thoughts, not just from sort of sitting in the Novartis Foundation, but also from your experience in pharma and some of your other experiences, and then merging in these themes of digital health, of AI. Take a few minutes, please, and just Give us Dr. Ann Aerts' view on where we are with regard to the theme of healthy longevity as a, let's say, an actionable target within the healthcare system, and some of the areas that you're most excited about, obviously, like the digital health, the AI. Are there other interesting things as you sit on the commission that you're seeing, I guess, in the challenges and so forth, that, wow, I'm excited about this, that's going to be very useful 5 years from now, or whatever? And obviously nothing confidential that you're seeing, but please, love to hear your thoughts on healthy longevity.
Yes, I think you can definitely use the word tsunami for the longevity coming up. And the goal of healthy longevity is definitely that we don't only see an increase in our lifespan, but also an increase in our healthy lifespan. So currently the life expectancy is increasing everywhere around the world since a long time, but the healthy life expectancy is not. And that is the problem, in fact. So we have to act earlier in life if we want to avoid that people get ill at earlier age, or get ill at an age where they could still be fit, in fact. Currently, we have the tendency to say the 60s is the new 40s, or I don't even know what it is now. Maybe 70s is the new 50s, I don't know. But still, there's a lot of people in their 70s or beginning 80s who really get a few health problems that become heavy. So it is a huge burden on the health systems. And currently we can look at Asia because they are already manifesting this. Such countries such as Japan and Singapore, and they are the most innovative, I think, in using our innovative technology available in helping elderly living healthy lives and living independently, which is definitely important for them. But looking at the overall situation, it's absolutely key that we look at longevity in a lifelong way, so that we don't only start when people get retired at 65 or whatever age, but we look from the childhood already. You can prevent a lot of your problems at older age. So we have to take this lifelong life course approach. And that's what we are doing, in fact, in the National Academies Commission as well. Now, I am not an expert in longevity, but why I am in that commission is definitely to look at how data, digital, and AI can influence it. And there it plays also in tandem with the working group on health and digital and AI and health that I chair at the Broadband Commission for Sustainable Development, which is really a public-private partnership led by ITU, UNESCO, bringing together all the different big technology companies and the authorities at the same meetings, where we really look at how can we build these multi-sector partnerships to address that. But digital and AI opens so many possibilities for helping elderly living healthier lives on one hand, and for tracing the health of people from the beginning of their life to the end of their life. So with AI becoming more and more available, we can start really looking at how we prevent people to get to a sick elderly age. And that is the beauty of AI, I believe, because it opens a whole new spectrum of longevity medicine, but then looking at even childhood diseases, teenage behaviors, and working on all of these different data sources to understand better how we can people keep healthy as long as possible. That being said, we also know from our last report with the Broadband Commission that AI is already having a tremendous impact on the health of many people. And an example would be that you can really help people recognizing that they have certain symptoms and help them having a patient-facing solution that can help them direct to the right services. Or in Singapore, they use digital to keep people in specific living conditions able to remain independent, really because they have much more connection to social workers or health workers. They don't feel so lonely. They have assistance to express their needs or questions or fears. So we can learn a lot of all the examples that are already out there. And I think we are going to look at this very different now in a few years from now. Look at one example I remember from our report, for example, in China is Ping An Good Doctor. It's one solution by a Chinese insurance company, and they wanted to provide all Chinese families with a physician, with a health record, and with a health management plan. But they deliver 24/7 services for everyone through their internet-based hospitals, internet health centers, internet pharmacies, even delivering at home. And they have 1 billion consultations a day. They already cover more than 300 million people. Right. So you can imagine these kind of solutions are a huge response to the burgeoning health needs of elderly as well. Then you can get the healthcare you need at home, let alone all the extra devices you could have to monitor your heart failure, your weight, and all these things which make it even more complicated than having someone to talk to. So I believe in the most simple solutions always. For every technology solution, the simpler it is, the better it is. The less extra technology you have to introduce, the better it is. And I see that this solution like Ping An Good Doctor demonstrates it again. You just have to have a phone to be able to get access to all these connections. So there is a lot out there, but there's still a lot to discover. And in research, the geroscience, as they call it, the science for healthy longevity, they are advancing at very fast pace to understand what keeps us younger, longer. So I am very, very much enthusiastic about this commission because we are learning every time we meet from new developments that are coming up.
And just one other thing related to that, as you talk about sort of this concept of aging in place, and then obviously technology, smart home, smart health. Any other, while I have you, any other interesting tools that you are looking at that you can talk about, in terms of as I'm here in my house and the environment has been such that more and more, as you were saying, are going to be home focused, and a lot of elderly people want to not be in an age home, but they want to age in place. I think that's the right term. Any other interesting tools, whether they be digital health, AI, that are really exciting to you in this space?
Well, I don't really want to pinpoint one, but what I have fresh memories of, and it was my last trip before the lockdown, in fact, was we visited in Singapore, a setting where they built, it's not a digital solution per se, but a setting where in very huge skyscrapers, of course, there were different services for keeping elderly people as long as possible in their homes. And the homes are all in the skyscraper, but then elderly can come down. There's like a marketplace with all food stalls where you can get whatever food you like. There's a theater where they have performances. There's a kind of atelier where they can be creative and develop their own art or tools they are working on to be together. There's a garden on the roof where they can do their gardening. So I feel this kind of combined addressing all of the needs of a person who lives by him or herself and who needs to stay in touch. As we all know, the relations you have at old age are the ones that keep you healthiest. It's the biggest factor for remaining healthy, is having healthy relationships and being not on your own and not too much lonely. So I feel the Singapore model has really addressed that. And it's fantastic if you listen to the people who are living there. So they can choose the type of home they want. Whenever they have a kind of a physical hindrance, they can go to an apartment that has more aids available, where when they are still fit enough, they can stay on the top floors where they can be much more independent and do other things. So it is really interesting, these concepts of like cities. It's small cities specifically designed to the needs of keeping elderly people happy and able to live a joyful life. And that's what I looked up most at, because I cannot imagine we are going to do that here. We have such another mentality, in fact, in Europe. And for living, you would, if you compare that to the retirement homes here, it's pretty different. It's drastic. If you move from your own home here to a retirement home, it's really drastic. And there I felt people are very happy, and it's a privilege to be able to join a park like that, if you may. So that was really fantastic.
That's fascinating. Like when I see some of those things in other pockets of the corners of the world, I'm like, we need models like that here as well. In the US.
It's true. It's true.
And I want to now just, if you would, I'm going to take a little journey to an earlier part of your career, just to get your insights on the matter. Obviously, we were talking about how obviously COVID has now focused us appropriately on some of these non-communicable diseases. I just happened to do a show on the topic of tuberculosis. 10 million cases, 1.5 million deaths around the world annually. We are working with the BCG vaccine, which is 100 years old.
Yes.
As of this year. We're dealing with antibiotics that are from the 1940s.
Yeah.
I guess COVID showed us that we could do vaccine development pretty quickly. Then I was shocked to hear about this tuberculosis vaccine that has been 18 years in development, is not predicted to be released until the year 2027, which really had me shaking my head. Obviously, this is not a simple answer, but if I could just tap into your expertise and the time you spend on tuberculosis. Once again, we're dealing with something here that's in the poorer countries. We don't think about it, but it surpasses malaria, surpasses HIV. Can you give me, the Dr. Ann Aerts, a couple minute thoughts on tuberculosis and where we are today?
Yeah, tuberculosis is the most complex disease we have, I guess. Maybe not as complex as COVID, I should say, but tuberculosis is a bacterium, and we shouldn't forget that. So it's Mycobacterium tuberculosis, it's called, and it's a bacterium that grows very slowly. So you need to culture it in the laboratory. For example, you need to leave it almost 3 weeks a month to see that it can grow. So that is probably the reason why we don't have a vaccine besides BCG, because all vaccines we have is against viruses. And a vaccine against a bacterial disease is pretty complex. So we are very lucky to have this BCG, although I agree it's scandalous that it's 100 years old and we still didn't get rid of tuberculosis. The reason being that BCG doesn't prevent you really from getting it, but it prevents you from getting really serious tuberculosis in general. So in the end, TB is so complex because it is a bacterium that finds ways to escape everything. It's the same type and family of leprosy. Yeah? That's why it's Mycobacterium leprosy, why we are not able to really get rid of it. It's such a complex thing. Even the leprosy bacteria, you cannot culture it in the lab. Tuberculosis, we can. But we use even the same medicines for those two diseases. And that is still very efficient. But in the end, we should really be able to have new medicines. And I'm not counting on a new vaccine for tuberculosis, but there are new medicines that have been developed in tuberculosis. So that's definitely a positive sign. But how fast we will, in the end, be able to reduce the tuberculosis burden, which is, as you said, the highest mortality amongst all infectious diseases currently. I don't know how long it will last, but it will require an enormous effort and an enormous effort from many different sectors again. It cannot only come from the health sector because it is also a socially determined disease as well.
Mm-hmm. Well, I appreciate your insight. I know that you have worked on it a few years, but it's just some shocking figures. And hopefully we can learn, as we have with COVID, on how to speed things up. But
I hope so too. It would be great. Yes, it would be great.
Um, and typically at this point of this show, I come back to our guest, and looking at your career, you have no doubt in government, in industry, and academia, have met many fascinating people. I'd like if you would just to take some time, obviously not name everybody, but specific people, mentors, influencers that have been very important in, as Dr. Ann Aerts has been out there doing what you've been doing, the types of people, if it wasn't for them, that you may be off practicing law or selling real estate or doing something totally different. Take some time, if you would, just to shout out to or mention anyone that you want to that has been really important to you as you've been on this amazing path.
Yeah, I have so many people who have been very important to me in my life. I mean, and also in my choices for career. In fact, I think the ones who have been very, very inspiring to me are public health leaders or thought leaders in the space of population health, such as currently in my board of the Novartis Foundation, I have Peter Payot, who's the former founder of USAID and who made these HIV therapies possible around the world, in also bringing together all the necessary partners for that. So that's a real inspiration for me, Peter. Then I met with so many important people on the ground while I was working in different countries, but also another Peter is Peter Lamty, who is a Ghanese professor and who really influenced me on how important public health is. If you are a medical doctor and you stand on the ground, you can only do as much as you can do in one day, maybe 30 patients, 50 patients, maybe in really emergency settings where you can triage and delegate, you can do 100, but it doesn't change the health of a mass of the main part of the population and who's continuing to live with the unequal access and unequal quality of care. So you have to look at it in a different way. So that influence from going as a medical physician, providing clinical care, to becoming a public health physician, providing population health and care, that has been a really important step in my career. And someone else, some very powerful women have helped me there as well, like Professor Portals, who was one of the professors who helped us identify the multi-drug tuberculosis in the prisons of ex-USSR, and who discovered this in her lab in Antwerp. In fact, you are dealing with multi-drug resistant TB, which we had never seen before. So resistant to all the existing drugs. And that was really a very interesting partnership. Also, many other people dear to my heart and in the private sector, leaders in the private sector have amazed me of how, like in our company now, we are focusing on being servant leaders instead of top-down bosses. We want to have an unbossed culture that is very inspirational for me as well. So I see lots of role models in my current company for that too. And then obviously my team members and my children, they coach me a lot and they teach me the hard lessons in life, I would say. But definitely, yeah, I can shout out to many, many people, and my family as well, and my parents who are not here anymore, but they have always supported me and believed in me, even if I was taking a path they didn't know at all, and they were not very familiar with it either. But yeah, I think it's too many people to enumerate here, but many thanks, I should say, around the world.
Definitely. I can only imagine you telling your parents back in the day that you were going to go into a prison to check on drug-resistant tuberculosis. But I can understand that they might be reticent to that. But
yeah.
It's really been fascinating listening to you and listening to this amazing journey you've been on, and really wishing you and everything you're doing in the foundation much success moving it all forward. for everybody that's going to be listening on the podcast or watching on the YouTube channel, you've been listening to Dr. Ann Aerts, head of the Novartis Foundation, who is passionate about transformation of the health of low-income populations using data, digital technologies, artificial intelligence, as they say, reimagining health and healthcare all around the world for everyone. And it's been a real honor and privilege talking to you about these topics. I want to thank you for taking the time out of your schedule again, for doing this, for talking to us for a little while. And as we say on the show, thank you for helping to create the better tomorrow through everything you're doing. It's a very, very fascinating and inspiring.
All thanks to you, Ira. It was a real pleasure to talk to you.
It was a very much pleasure here.